Hi guys, welcome back to another video. I'm Dr. Downey and today we're going to talk about blood tests in athletes. So this also applies to bodybuilders and other sport enthusiasts, and essentially we're going to look at how you should interpret certain markers as an athlete. Since our values or reference ranges will be slightly different from that observed of a normal sedentary population. So, as always, I am available to interpret your blood work for you. However, if you prefer doing it by yourself, this is just a quick guide on interpreting markers from an athletic standpoint. So first of all, we'll start with the liver with AST and ALT. These are transaminases commonly found in liver cells or hepatocytes, and they tend to be released when there is destruction of these liver cells, and that raises the level, and that would indicate liver damage. So whilst they are found in hepatocytes, they are found in other cells in the body. However, ALT, when looking at that, that's mainly found in the liver, whereas AST, whilst it is found in the liver, can also be found in many other tissues and is not so specific to the liver. So it can be found in the muscles in quite high quantities. And there is a strong positive correlation between your BMI and ALT, which is important to take into account since bodybuilders tend to have a higher BMI, which means their ALT might not be as low as they would want it to be. Obviously, if it's too high, that is an issue, but slight elevation can be normal in certain circumstances. It all depends on the clinical picture. If you have typical symptoms of liver damage, then an elevation is problematic. And it's important to note that AST is released from the muscles during exercise, especially when there's damage to the muscle, and this would result in false positives. So I also mentioned that bilirubin, which is another indicator of liver damage or poor liver conjugation, that could be found in high quantities also after exercise, because sometimes an exercise is hemolysis, which results in breakdown of blood cells, and that gets all converted into biliverdin and bilirubin and things like that. So secondly, I wanted to touch on creatine kinase, because this is always elevated in athletes and elevated to very high levels. So it's used in cardiology, however, it's not so useful in athletes. It's used to pick up damage to the heart and things like that, as well as it is used in cases where someone has muscle trauma or rhabdomyolysis, where their cells of the muscle are being destroyed, and this affects the kidneys. It's not the creatine kinase itself that affects the kidneys, it's the myoglobin that affects the kidneys, since creatine kinase is actually cleared by your plasma, by the phagocytic cells like macrophages. It's not cleared by the kidneys. It is commonly increased after eccentric exercise, so highly stressing the eccentric portion of an exercise does seem to produce higher creatine kinase levels, and it peaks a few hours after exercise. And the more intense your exercise is, the more elevated creatine kinase will be, and it is used as a marker to indicate overtraining, because if you have high resting creatine kinase, much higher than that of the normal level, constantly could mean you are overtraining. But then again, it might not indicate that. So the reference range for athletes is, there still isn't a defined reference range, but it's somewhere from 1,000 to 2,000. It's still considered normal, not ideal, because it could mean you're overtraining and you don't want it to be that level all the time, but that's just important to know. So let's look at creatinine, which is usually used to indicate kidney function, and it's elevated when your kidneys start decreasing in function. Urea isn't a great marker in this case because urea is not really influenced by exercise, and it's not a good marker of kidney function. It's more used in chronic conditions or chronic kidney disorders. So also creatinine is used to calculate the estimated glomerular filtration rate, which is essentially the rate your kidney is filtering stuff, which would ideally needs to be higher than lower. Your creatinine can be influenced by your BMI and muscle mass especially, and it seems to be influenced by your phase of training. If you're going into competition stages, that it tends to lower after competitions or during competitions, surprisingly. And it's not, you shouldn't look at creatinine in isolation. If you are looking at it, compare it to your previous levels. If it is increased, if it is high, but the trend has stayed the same, since obviously it's always important to ensure that your kidneys are functioning fine, and creatinine isn't the only way to test that. You can use ultrasounds and things like that. But if it has been high in the past, but the value isn't changing, then it's more important just to compare it to yourself and not the reference range, because if there's deviation from your baseline, then that would indicate kidney damage. So your estimated glomerular filtration rate is just an estimate. It's used, there are a lot of things that are assumed with this calculation. It takes creatinine into the consideration, gender, age, it's all kind of generalized, and there are different calculation methods they used there, which I've outlined here. There are 3 different types of equations that I know of, and GFR tends to decrease quite drastically, especially after endurance training, but that's due to dehydration and things like that. So dehydration does influence it. High protein intake will acutely influence it. Training variations also influence estimated glomerular filtration rate. And it's found that the GC and MCQE equations are a lot better because they aren't as susceptible to change in these variations of training, because training intensity will change the GFR. But a better measure in athletes of your GFR is cystatin C, which is a low molecular weight protein that is filtered through the kidneys. Remember, the kidneys do not tend to filter proteins, but this is a small one that is filtered and reabsorbed back into your system. And it's not influenced by age, gender, BMI like creatinine is. And it still is influenced by things like muscle damage and muscle mass, however, not to the same extent of creatinine. It's less than half of the influence. So it's a better alternative to creatinine for calculation of your GFR, and it's more accurate in athletes, but remember, it still can be influenced by muscle damage. Now we move on to more of the heart-specific biomarkers. So your troponins, your troponin Ts, if you've ever heard of that, they're usually indicated to pick up myocardial ischemia, or lack of blood flow to an area of the heart, which results in lack of oxygen. And whilst it's normal to have an elevation in them, they can be elevated after strenuous exercise, because during strenuous exercise you have periods of anaerobic respiration where the heart isn't getting as much oxygen because you're straining it, and during that period the membrane of the heart cells starts to form like blebs, and these blebs get released into the system, and therefore you have troponin circulating after strenuous exercise. So in this case, it should not be, in the case of an athlete, it shouldn't always, a rise shouldn't always be interpreted as cardiac damage, especially if it's a slight rise. A massive rise is not normal in most circumstances, and you shouldn't interpret it as cardiac damage or heart damage if you don't have symptoms or radiological findings that would suggest that it is due to actual proper myocardial ischemia. So then we have NT-proBNP, which is N-terminal proBNP. Essentially, it's cleaved form of BNP. It's not the best marker for heart failure, although it is used in heart failure. I haven't seen it used that often. And it tends to indicate stress of the actual wall of the heart, and it's released when the heart wall is stressed, like in cases of high blood pressure causing a left ventricular hypertrophy and things like that, and then proBNP increases. And the point of it increasing is because it has functions such as natriuresis, which is essentially getting rid of sodium retention and water along with that, which during heart failure is beneficial. Vasodilation, and it antagonizes the RAAS system, as we've spoken about many times, and it's also important in controlling and protecting heart cells and controlling the growth of the said heart cells. So yes, it is used to indicate heart failure or possible heart failure, but it does increase after exercise, and athletes will tend to have higher levels because their myocardium or their heart is essentially adapting to the training that is occurring. So it's not just indicative of wall stress, it's also indicative of remodeling. And lastly, we have uric acid, which is, if you have high uric acid, you don't have gout. Gout is a clinical syndrome where you also have high uric acid, but it can predispose you to gout. At low levels, it's actually it works as an antioxidant, but when it starts reaching high levels, it's a pro-oxidant. So it is used in the muscle during exercise because of its antioxidant abilities. It's absorbed into the muscle and it prevents oxidative stress to the muscle, or helps with that. So after exercise, it does increase quite a bit. So if you get a blood test after exercise, uric acid might be off. However, if your resting levels should not be influenced by exercise. So essentially, if you have high resting levels of uric acid, that is problematic. So I hope you learned something from this video. If you did, let me know in the comments below and let me know what you think. And remember, these are just markers to look out for. If they are skewed, remember to question it and see whether or not it's normal in athletes. Thank you for watching.